So welcome everybody, and I'm just going to quickly show you the agenda. You can see it there. So we've got me chairing. I'm then going to just talk a little bit. I'm not going to talk too much about the white paper because that's been covered by the other speakers, but I'm just going to talk a little bit about that. And then I'm going to hand over to Vic Rayner first of all, then Helen Hayes. Then we'll have some question and answer opportunity. I'll come back to that shortly before we move on to our second three speakers, who I will introduce at the time: Rachel Dodgson, Gavin Edwards and Laura Guntrip, before we come back to some questions and answers for the second three speakers. Next slide, please. So having mentioned Q&A, if you all look at the bottom of your Zoom screen, you'll be able to see a Q&A tag at the bottom. If you put your questions in there, I will do my best to get them to the right person. If you want them addressed to a certain panelist, then say so on your question. Otherwise, I will pass it to the panelist I think might be best able to answer it. If you put your questions in chat, I might miss it, so do try and put it in the questions and answers, please. I've just seen somebody's asked if the slides will be made available. I believe that they'll be shared afterwards. They usually are, but I'm sure somebody will correct me in the chat there if I'm wrong. Okay, next slide, please. So here's just a reminder to get nominating. We've got some fantastic people working across social care. So do get nominating for the Great British Care Awards. We've got the deadline is the 17th of September, and we've got the Social Care Top 30 and the Learning Disability and Autism Awards. So do get nominating for that. As well as that, the Social Care COVID Heroes, which are up on the screen now, is one of the categories in the Great British Care Award nominations. So do all get nominating. I'm sure that yourselves and people that you're working with, coming into contact with, really deserve some recognition. So let's get nominating and give them that recognition they deserve, especially after the very, very difficult year that we've had. So we've got our live conference in June, where we really hope to be able to get everybody face to face. We've got a fantastic lineup of speakers there. And I know that some of us are really looking forward to being able to get back together at a face-to-face conference and being able to do a bit of networking and see each other. So do get your tickets booked. Okay, so now over to me. So as I say, I'm Catherine Smith, the Chief Executive at the Social Care Institute for Excellence. I'm not going to talk too much about the white paper. I'm just going to touch on the white paper. Next slide, please. So when the white paper was published, this was the response that, well, a summary of the response that SCIE submitted, which is that we do welcome the white paper in that it's aiming to see that social care is fit for purpose. And we very, very much support the need for stronger partnerships at that local level, driving improvement. And I think one of the things that we really wanted to be recognised is that the further away you are from decision making, the more powerless people can be. And so we really feel it's quite important that decision making is brought closer to where the care is happening. And so these proposals give us a good opportunity to tackle that issue. Next slide, please. However, the integrated care systems governance structure was announced this week, and I think one of the issues that we would want to flag, and that we will flag, is that there is only one local authority person on a board of 10, which could potentially be quite a lonely place and an unbalanced voice. The integrated care system boards will be deciding finances and services, and they're expected to be considering strategies drawn up by separate ICS partnership boards. They'll also be given a statutory status in the new Health and Social Care Bill, which we're expecting to be laid before Parliament in the coming weeks. So I think what we feel is that this document really helps to provide some clarity around the direction of travel for integrated care systems and allows some room for the flexibility of systems to be designed and configured to meet local needs. But I think what we feel is really missing, what we'd like to see more of, is that voice of lived experience and the social care voice really recognised within there. So we will be pushing more and more for that. Next slide, please. And ultimately, the reason why we would want to push for that is because we are aiming for this, this vision that has been articulated by Social Care Futures, which I think is pretty difficult to argue with, really. And the vision is quite simple there. Don't we all want to live in the place we call home, with the people and things that we love, in communities where we look out for one another, doing the things that matter to us? And for us, that's a vision that we're striving to achieve, and the people that we work with and the people that draw on care and support are striving to achieve that vision. And we're looking to see how the white paper and any other social care reform can help to contribute to that vision. Next slide, please. So that leads me on to the latest news from our perspective, which is that along with several other organisations, we wrote to the Prime Minister, the Chancellor and the Secretary of State yesterday, where we're calling for proposals to be agreed by the summer recess on social care reform, and that reform is underpinned by the social care future vision that I just articulated to you. Essentially, we need to see social care as a key part of the solution and a key part of our infrastructure. Social care impacts so many people in so many communities, and there's so much interdependency with other public services that really it needs to be seen as a key part of our infrastructure and being given that kind of priority. And within this letter, we also expressed how much we feel the role of citizens and community groups is just as vital as the preventative services that we seek to see more of. Next slide, please. So we were specifically looking at 3 priority areas within our asks. One of those is about funding for short-term stabilisation. I think most of you would agree that the last year or so has brought quite a lot of challenges to the world, I suppose, but for the purposes of this conversation, particularly has brought challenges to the social care sector, where some of the inequalities that we already knew about were really, really highlighted through the COVID pandemic. And that's really pushed our systems to breaking point in some instances. So funding to stabilise us in the short term is really important. However, what we need is urgently bringing forward is the investment and the reform proposals for the sustainable long-term future of social care. And what we're not looking for is a return to how things were. What we are looking for is a reform to take us well into the future for social care that is fit for purpose and really seeks to bring that vision for social care to life. And then looking at investment in the shorter term to speed up that shift towards a system of social care that is both sustainable and fit for the modern age. And within that ask, we're looking very much at innovation and how we can trial new ways of working and get that innovation embedded into practice. The people that were signatories to that letter include Social Care Futures themselves, Think Local Act Personal, the Local Government Association, the Care Providers Alliance, and the Association of Directors of Adult Social Services. So we had signatories from across the board that are really pushing on the getting these priorities brought forward, and hopefully perhaps by the next time we speak at a future conference we might be able to update on what's happening with that. Next slide, please. If anybody wants any more information about SCIE or the work that SCIE is doing, then our information is there. Please do get in touch. Next slide, please. And for now, thank you. I'm going to move us back to introduce our next speaker, who is Vic Rayner. Vic Rayner is the Chief Executive of the National Care Forum, joining the organisation in 2016. The National Care Forum is the strongest voice for the not-for-profit care sector and works with its membership to drive forward the delivery of quality person-centred care. As Executive Director and Chief Executive, Vic is the Chair of the Government Strategic Advisory Forum on the social care workforce and co-chair of the National Social Care Advisory Group on social care and technology, as well as sitting on a range of government and national specialist groups with a focus on social care workforce, digital transformation, new models of care and regulation. Vic is a regular national and international speaker and has extensive knowledge and expertise across a wide range of care, support, housing and social policy agendas. And I think when this bio was written up, she hadn't yet received her OBE, but was announced last week that Vic was awarded an OBE in the Queen's Birthday Honours. So congratulations, Vic, on that. Very, very well deserved. And over to you. Thank you.
Wow, thank you very much, Catherine, for all of that long bio. I'll try and make it a bit shorter next time, but really delighted to be able to join the conference today and to be able to talk a little bit about the work associated with the white paper and perspectives on that important piece of legislation, some of the things that we hope it will achieve and some of the things that we're concerned about in the context of its limitations. So I have about 4 or 5 slides that I'm going to whip through, and hopefully we'll have some good opportunity for some discussion about it at the end. If we could have the next slide, please. Great. So the white paper that came out in March this year talked about the future framework, in a sense, for integration. Now, I mean, these are the sort of ambitions that are in there. And of course, these are really hard to argue against. Why wouldn't you want all of these things that are listed here in terms of the ambitions that are set out for integration? So improving population health and healthcare, absolutely the things that are essential and things that all communities would look towards. Tackling unequal outcomes and access to health and care, enhancing productivity and value for money. So within that, things around the workforce and things around digital developments and other areas that we'll look at. Helping the NHS to support broader social and economic development, and bringing health and care closer to community. So absolutely laudable aims and things that people would want and need. And in fact, for those who are using health and care services, things that they can't possibly understand why aren't already there in the context of integrated health and care services. But they're not there, and so the white paper is intended to kind of reinforce the framework for delivering that. But immediately on receipt of this, partly because it was billed as a kind of reform agenda around health and care, and partly because, unfortunately, it is an extraordinarily health-focused piece of legislation, it's really difficult for social care to not feel that we're missing some of the key players in terms of the decision making and the frameworks that are being put in place. It is, as I said, a very health-focused piece of legislation, and does absolutely, as Catherine says, miss many of those who are involved in the design and the creation and provision of social care, and very critically those who use those services. So right from the outset, some early concerns and challenges about how once these new frameworks are embedded in the legislation, how the voice of social care provision and the voice of those who use it will be heard at the top table. Next slide, please. So there is, for those of you who've had a chance to look at it, there are a series of bodies that are described within the legislation. And as Catherine says, the framework, the design framework for ICSs was released just last week. And that sets out what the different parties what they'll do and who will be involved in them. So ICS, it's a lot of jargon, the whole thing is full of jargon, but ICS is integrated care systems. And the design framework came out on the 16th of June, and it lays out who is part of what's called the Integrated Care Board, which is the sort of top table of this framework arrangements, and who will be at the Integrated Care Partnership Board, and then whatever else happens around it. So it's important to understand that this is a piece of legislation designed to embed some changes that have already begun to happen at local level. Depending on how well connected you are with what's happening at your local level, you may be aware that what was called the STPs, I've already forgotten their name, Sustainable Transformation Partnerships, have already moved over into ICSs, and those CCGs, those clinical commissioning groups, of which there are 140, have started to morph towards these integrated care systems. So we're moving from 140 CCGs to 42 ICSs. So The first piece of information to put in there is within the framework, the top level board is called the ICS NHS Body Board, which clearly you have to say in a way that doesn't make it sound like you're going surfing. So the ICS NHS Body Boards is probably how you're supposed to say it. And that idea is that it'll focus around health and provision. And at that top table, where the decision making, a lot of that early decision making will be happening, there is a place for the NHS Trust, for GPs, and for the local authority, alongside the clinical commissioning groups and other commissioning decision makers within health. So I think, just to reinforce the point that Catherine was making, the big concern there is you haven't got social care providers at that top table. And again, you haven't got people who use care and support and health services there either. Now, of course, if it wasn't important to have providers there, then you wouldn't have NHS trust representatives. And I think it's important to keep restating. You wouldn't, and I think this is what the framework shows us, is you wouldn't envisage having a discussion about what health provision should look like at an ICS level, at an integrated care system level, without that acute representation of what hospitals can do and what acute services can offer. So why is it okay to have exactly the same discussion about what social care should offer without social care provider representation? So we'll keep on hammering home about that point, and it'd be interesting to pick that up and discuss that further. So the framework does enable others to be included at that ICS NHS body board level, but it's important that we bring forward a concerted message about how social care providers and people can receive care and support can be represented there, and what that should look like in practice. And there's work going on with local care associations and discussions with national care bodies as well to understand whether we can work through that representation issue. Alongside the Integrated Care System boards, there is the Integrated Care System Partnerships Board, which does indeed have a much stronger role for care within it. And that partnership board is intended to look at the wider health and care needs of communities. But again, it's the decisions that it makes are non-binding on the ICS board, and it does certainly feel from the way the descriptions go that there is a top-down relationship between that partnership board and the ICS board. So good to see that social care representation is better understood at the partnership level, but important that we get it into that ICS board level as well. And alongside this, we still have things like health and wellbeing boards continuing to exist, where there will be social care voices and, of course, the voices of people who use care and support services. So important that their role continues to be sustained and understood and involved. We can move on to the next slide, please. Now, one of the really important bits of the legislation is it demonstrates the much greater understanding around data. And those of you working in social care will know that over this last year, we've gone through an absolute data revolution in the context of what data is available, what real-time data is available around social care, largely gathered through the capacity tracker mechanism, but also just how important data is beginning to be seen as for both health and care. Now, today, in fact, the draft health and care data strategy has just been launched. So for those of you keen to look at the latest information, it would be great to go in and have a look at that. That's out for consultation, and there'll be very active engagement, I hope, in that. And that will be something that will then come to fruition towards the end of the year. So that's really important that we get social care data in there. Capacity tracker is part of that, as I say, but that was created for a different reason and has played a really important role in terms of the social care COVID response. But the kind of data that's being talked about within the white paper is data that needs to be recognised at a particular standard, is intended to be interoperable. So that's a very long word for connecting, being able to connect up across systems, and it needs to be something that then meaningfully drives change and drives improvements in care. So there's a lot of work to be done around that standardization of data, and different initiatives are going on around that. So there's something called DATCHA, which is a university-led program which is looking to put together a national minimum data set for social care. There's work that we're doing within the National Care Forum around using one of the health data sets called SNOMED, which describes health characteristics, health interventions, and see if that could be coded into social care planning systems. Again, there's now an explicit intention that all social care organisations should begin to use electronic care planning systems by 2024. So really important sort of drivers around data being available. But some flags of concern there about the different philosophies around data in relation to how and why it's collected in health services and how and why it's collected in social care. And often that's kind of characterized as the difference between healthcare data being collected from diagnostic purposes and to describe interventions, whereas a lot of social care data is collected around the outcomes for people, and recognizing the changes that people are making for themselves, and how that is making them feel or think or wanting to do things differently. So we've got to get that data set right, and we've got to get the conditions in place for sharing of data. And there's a lot of work going on at the moment around supporting care organisations to take on board something called the Data Security and Protection Toolkit. If you're not aware of that, there's lots of local programmes that you can tap into around that, possibly being run by your local care association, or if you're not can't find it, then there's a programme called the Better Security, Better Care national programme that you can look that up through digital social care and find out where the support for that is. And that's really important because that's going to determine information governance requirements for the future. And I think we've also got to get to a place where we understand and we've got a shared view of why social care data matters. The legislation gives the Secretary of State an opportunity to mandate the collection of that data, but we know from all sorts of work, I mean, I've been involved in loads of data work over many years, and one of the biggest challenges about data is making sure that you get the right information put in. And in order for people to be able to put in the right information, they need to understand why it's important and what's going to happen with it. How is it going to change things? How is it going to drive improvements? And as I say, that data strategy is out. It needs to absolutely have the voice of care providers in that and people who use care and support. So look out for that consultation. I'll try and put the link into the chat after I finish speaking. Next slide, please. Thank you very much. There's another part of the white paper which looks at assurance. And the changes around assurance, so regulation, making sure things are happening the way they should, is that the proposal is for the Care Quality Commission to have a greater role in terms of looking at local authorities and working out whether the part that they play in the overall delivery of care across the country. Now, this is really important and something that lots of care providers have been asking for and looking for over the years, and indeed is a role that, in the context of assurance, was played in different settings with local authorities by the National Audit Office and various other functions in the past. So it's interesting to see how some of these things work their way back again. So the Care Quality Commission have absolutely critical information about how health and care works together. And obviously a key element of that from a provider's point of view is how services are commissioned, how needs are determined, how markets are managed. So it's important to see that this is going to come in as part of the overall regulatory system. So we welcome that, but we need that detail. And crucially, as with all of these changes, understanding what difference it will make on the ground when that system is in place. So we've seen various iterations of this, perhaps, precursors of this through the local systems reviews work that CQC have done in the past. But it would be interesting to understand then what teeth either central government believes it to have or CQC has in order to make differences and to make meaningful changes if they identify that there are challenges around the commissioning, provision, market management, etc. at a local authority level. Next slide, please. So reform wise, Catherine's already started us on some of this discussion, and I think one of the biggest concerns was when this white paper came out was that this would end up being billed in some way as a key element of social care reform, whereas in fact a lot of what we feel is happening with this white paper is a reinforcement and a kind of legislative focus on some of the reorganisation of health systems. The white paper includes in there the promise of reform, and as we know, the Queen's speech included those 9 little words about social care reform, about the government bringing forward social care reform within this year. I mean, this promise of reform is absolutely not enough, and we have to get ourselves to a place where we've got something to look at, to talk about, to debate, to discuss, which will help us to understand what we want for the social care of the future. I absolutely agree with the statement that Catherine had from Social Care Future. We know a lot of what we want that to look like, but we need to work through the steps in order to get us there. And we need to see that articulated by the government, not at the end of the year, but now. And I think for me, a really big concern is that if we don't get that clearly out there, then we're going to find that social care has to reform within the bandwidth or within the strictures that are put in place by those ICS frameworks. Now, I've said that ICSs are going to move into 42 ICS integrated care systems across the country, but that in itself sets a set of expectations around what that scale of social care reform change should look like. Is that the right place? Is that the right model? Are those the right systems and players around the table in order to facilitate proper reform? And of course it might be, but we don't know at this stage, and that feels really, really limiting for social care and concerning for how that further reform programme will look like. Social care isn't there to fulfil those objectives of the NHS, and the risk is that the framework that's been put in place may end up feeling more like that than something which is looking to be a joint endeavour with outcomes for all. And I think some of the things that the ICS and indeed the partnerships are intended to do are about the key issues for reform that we know are really going to be vitally important for the future, which is around workforce reform, digital reform, integration and beyond. And I think the risk is the voices of those who receive care and support services and the voices of those who deliver social care are not sufficiently embedded or required at the tables where these decisions will be made. And without those, we could be looking at integrated workforce plans, for example, that don't properly reflect the kind of care and support that we need for people, the workforce that we need to deliver the kind of care and support that we want for the future, or don't fully recognise the kind of digital challenges that individual social care organisations have, and we end up with what sounds like an integrated system, but on the ground feels very like a system designed to support the integration of the NHS with social care provision and the people who use care and support services as an afterthought. And so we have an opportunity now to really think about how we can influence that and make sure that we get it moving in a direction that properly reflects the ambitions of reform for social care, so that we have a set of systems that are fit for now and very critically for the future. Final slide, thanks. So that's me done, Catherine. So over to you.
Thank you so much, Vic. That was really, really good, really insightful, and I think very thought-provoking for many of us. remember, if anybody's got any questions, if you could put them in the Q&A at the bottom, if you've got any questions for Vic, and we'll come back to them after we've heard the next speaker. So on that, I'm now going to introduce Helen Hayes. Helen is the Labour MP for Dulwich and West Norwood, first elected in 2015 and then re-elected in 2017 and 19. Before entering Parliament, Helen was a town planner for 20 years, working with communities to deliver new jobs and homes, and a councillor for Southwark Council's College Ward from 2010 to 16. Helen currently sits on the Environmental Audit Committee and was a member of the Housing, Communities and Local Government Select Committee from 2015 to 2019. Helen continues to work closely on these issues alongside climate change, healthcare, education, the Windrush generation, mental health and learning disabilities, and she's a former Shadow Minister in the Cabinet Office and a co-chair of the All-Party Parliamentary Group on Adult Social Care. So thank you and welcome, Helen. Over to you.
Thank you very much, Catherine. I'm really delighted to have the opportunity to join you today and also to follow Vic Rayner. And I should say congratulations to Vic on being recognised very recently in the Queen's birthday honours, a richly deserved recognition for all of your work and commitment to social care over many years, and the work of National Care Forum. As a co-chair for the All-Party Parliamentary Group for Adult Social Care, it's been a huge privilege for me to have been meeting almost every week, certainly throughout the first 9 months of the pandemic. We were meeting every week with our working group for the APPG, drawn from a very wide group of organisations and individuals with an interest in care. These include care home providers, home care providers, the National Care Forum, Skills for Care, and individuals with lived experience of receiving care and managing their own care at home. Week by week throughout the pandemic, we have discussed what was happening in the care sector on the ground, including many of the very significant challenges like the lack of access to PPE and testing, hospital discharges and infections in care homes, and successive waves of government announcements on visiting arrangements. It's been said many times before, but it is so clear that the delays in bringing forward social care reform prior to the pandemic left the sector unprepared and very vulnerable in the face of this crisis. We saw firsthand the total absence of a protective ring around care homes and the appalling impact of that in the tragically high death toll in care homes and amongst vulnerable people. So I want to start today by paying tribute to everyone who works in social care and to unpaid carers for all that you have done during the pandemic. Today is also Windrush Day, so it also seems fitting to acknowledge specifically the diversity of the social care workforce and our reliance on people from all over the world who've chosen to come to the UK to work in social care. We often talk about the many challenges facing the social care sector, but it's important always that we give due recognition to the extraordinary commitment, skill and compassion of social care workers and acknowledge how many have gone above and beyond the call of duty over the past year in many different ways. Turning to the question of the white paper, my answer to the question, does the white paper overshadow the need for social care reform, is straightforwardly yes. The focus of the white paper, as Vic has said, is integration of health and social care. This has been long discussed, that there's a wide consensus that it is what is needed, and it's already happening in some places, most notably in Greater Manchester. But the discussion about integration assumes a level of equality between the things which are being integrated. And the NHS and social care in the UK are simply not on an equal footing. We have in our amazing NHS a mature, well-established health system. Social care, on the other hand, is fragmented and disjointed. It still cannot be taken for granted in any discussion of social care that everyone in the room will remember that social care is not only for older people, but that in fact a majority of social care funding is spent on working age adults. In discussing adult social care, children's social care is rarely referenced. In contrast with the NHS, there are a multitude of social care providers operating in many different ways in a wide range of different settings, from supporting individuals at home to large-scale care homes and supported living, some for-profit, some not-for-profit, as well as unpaid carers. There are a range of different funding mechanisms and costs to private individuals, and collaboration and co-production are vitally important aspects of social care. So reforming the governance and delivery structures for health and social care without reforming social care to place it on an equal footing with health will only transpose all of the current challenges facing social care onto a different structure. It won't solve them. And that isn't just my view. The Health and Social Care Select Committee, which is a cross-party committee with a majority of Conservative MPs on it, has said the absence of a fully funded plan for social care has the potential to destabilise integrated care systems and undermine their success. And the Local Government Association has also said it is disappointing that the government's immediate priority for social care is to strengthen national oversight of care and support, rather than bring forward its long-awaited wider funding reforms to support people of all ages to live the life they want to lead. My key concerns about the government's approach to integrating health and social care without first reforming social care are as follows. First, without reform, social care will remain chronically underfunded. The funding gap in social care has been quantified, as has the number of people who need care who are currently being refused it due to a lack of funding, currently estimated at 13,000 people every single week. Without reform of funding, we'll continue to see the thresholds for care rise, and we will continue to see some families facing catastrophic care costs. There is considerable cross-party consensus, including a report from the Housing, Communities and Local Government Select Committee in the last Parliament, when I was a member of that committee, that care should be provided free at the point of delivery, like NHS services. And this reform would be one step towards placing social care on an equal footing with health. Second, without reform, there is no social care system. We need reform to articulate a vision for social care for working age adults, older people and children. Integration without reform won't remove the battles that so many families who find themselves in need of social care face to figure out the funding and eligibility and navigate a complex landscape of different providers funded and regulated in different ways. Third, without reform, there is no solution to the recruitment and retention of social care staff. There are already more than 110,000 vacancies in social care, and that is set to rise as so many social care workers have experienced trauma, exhaustion and burnout during the pandemic. Social care work is highly skilled and challenging, as well as very rewarding, but we cannot continue to expect people to work in social care when they can earn more in the local supermarket and receive a discount on their weekly shop at the same time. We urgently need reform of social care pay and career progression to retain the highly valued staff we have already and to attract more people into social care as a rewarding vocational career. Integration without reform won't deliver this. Finally, without reform, there will continue to be significant governance problems for integration. The government's proposals allow for local authorities to be represented on ICS boards and partnerships. That's clearly important, but local authorities are only one part of a diverse and fragmented social care sector. As Vic mentioned, the white paper only allows for one local authority representative on an ICS board, but ICSs cover a much wider geography than local authority areas, and these differing spatial scales make local accountability really difficult. So you'd end up with one local authority representative representing potentially many different local authorities within an ICS area. Local councillors who have political accountability for social care can be far removed from the day-to-day operational role of an organisation operating across many different boroughs. All of this speaks to the immense frustration, and I don't think it's any exaggeration to say anger, at the government's refusal to bring forward urgently needed social care reform after more than a decade in power. There has been a huge amount of cross-party work on this issue by select committees, all-party parliamentary groups, independent commissions, think tanks, and many within the sector. The range of options for reform are mapped out. International good practice is well understood. It is now for the government to bring forward proposals, a vision for social care and reform of funding and delivery, and most importantly, a process for securing cross-party agreement so that social care is no longer the political football that it's been in the past. Next month will mark 2 years since the Prime Minister stood on the steps of Downing Street and told us he had prepared a plan. At this point, we just need to see it. Back to you, Catherine.
That's great. Thank you so much, Helen. And we've got some great questions that have come in for both yourself and Vic. So I'm going to, oh, my question's moved then. I'm just going to go to the questions. So if I start with you, Vic, just to give Helen a moment to catch her breath. So Vic, I'm not sure if you will know the answer to this, but I'll ask you anyway. So Sharon Davis has asked about data collection and said that there's some interesting comments from Vic on this area, but asked, is it likely that Skills for Care will be collecting this data in the future, as this is linked to some workforce funding, so may create an unintended outcome?
Yeah, I'm happy to try and talk about that. So I think what's being talked about is the national minimum data set that Social Skills for Care collect, which is very specifically around workforce data. And I think it's an interesting thing. So prior to the pandemic, that really was kind of our core source of data in relation to workforce. The challenge, I think, is that data set has generally been collected on an annual or less regular basis, certainly than capacity tracker, which is needed to be completed much more regularly. You're right, it enables access to the Workforce Development Fund training, and of course what you wouldn't want to do is create a situation where people were not being able to access that because we changed the method of data collection. I think the bigger question probably is, as with all data, is trying to understand what you really are trying to achieve with that. And I think for me, the biggest opportunity with data is that we use it to really transform the way that care is delivered. And I think we're beginning to see pre-pandemic and during the pandemic some fantastic examples of, particularly around the data associated with care planning, a real understanding of how data can help us shape the support and the care that's offered to individuals based around the outcomes that they really want to achieve. And I think that's where I was talking about the slightly different data philosophies, because the Skills for Care data is intending to sort of provide a picture of what the workforce looks like, but I'm not sure that it's telling us particularly how those workforce are delivering, or what the impact of learning and development is for that workforce, for example, in terms of changing the shape and method of delivery of care and support. So I think that's where we need to be focusing our attention on how do we get the right set of data that tells us about how care is delivered and what it actually does, and how it enables people to live independently, rather than what I fear we will be looking at is the mandated data being intended to only support regulation and only support assurance in terms of a smaller suite of issues. And of course, we have to be really careful. What we've seen is lots and lots of data mission creep over the last 6 to 9 months, as it's become apparent that there's a lot of real-time data that can be collected from care. Everybody's got an opinion on what's needed and what the appropriate measures are, which is why projects such as the DACHA project I've mentioned, which has got a look at what a national minimum data set like, are really important, because that will enable us to sort of really work with people who receive care and support and work with providers to understand what's important in that minimum data set.
Great, thank you. And whilst I've got you, Vic, you might feel that you've covered this one, but another question on data from Trevor Clower. He says the data is not seeing what is happening in the local work that is done. The examples of social care and health working together now at a local level, and he's given some examples on the Virtual Carers Roadshow on YouTube. These local examples are not recognised by the ICS in any meaningful way. I think that's kind of where you're going, what you're saying, really, isn't it, Vic?
I think so. I mean, it's you know, there's a couple of fundamental questions, aren't there? And you can see this being played out in the discussion about health data. You know, whose data is it? And who's got ownership of that data, and who should have a say in how it's used? And I think that's a great example, Trevor, of some, you know, of a local initiative, which is hopefully, I'm not familiar with the example, but is maybe showing the way in which local support initiatives around carers is helping people and making real changes to their lives. How do we make sure that that evidence then gets translated into the kind of commissioning and decisions that are made at these very high level boards. And I think it's, you know, and how do we make sure that the data you collect about those local initiatives is then delivered in a format that is standardized and can be connected and communicated and compared with the other data that sits across the health and care system. So there's lots of work to be done about how we bring those things together. And I think somebody else talked about the big distinction about qualitative data, which social care is full of, much of it written on paper, but you know, we'll get to a point where it's codified and put into care planning. But a lot of that's qualitative versus the NHS, which has got very used to measuring data in quantitative terms, number terms, often, which are then linked to financial incentives or penalisation. So, you know, we've got quite different cultures of approach to that data.
That's great. Thank you, Vic. And I'm going to consider the question on qualitative and quantitative data answered there. So thank you. Next question to Helen, please. So Helen, given the work of the AGGP, it says there, but it's the wrong way around. What are your views on the forthcoming Freedom of Information release from CQC, which Rees feels will do nothing to benefit the sector and instead will be devastating for those impacted by the pandemic and the crises affecting the sector, further vilifying providers and acting as an opportunity for the media to provide local league tables of fear? What do you think about that, Helen?
Thank you very much. I think Rees is referring to the data release around deaths in care homes during the pandemic, and I think, I mean, I think on that, I suppose I think that for families and people who are directly affected, that level of transparency is important, and it will be important, and that data would come out, you know, we would hope as part of, if not through a Freedom of Information request, then as part of the forthcoming public inquiry on COVID, we would, you know, need that level of data in order to understand everything that happened during the pandemic. But it is important that a data release of that kind is set in a context of what we know was the situation facing care homes. And we know that with the best will in the world, COVID got into many care homes in ways that individual providers had absolutely no control over, because it happened via hospital discharges, via patients who they didn't know were infected being discharged into care homes. We know that the shortage of PPE was absolutely chronic across the social care sector, and that many care homes were left unable to protect their staff and their residents because they didn't have the physical equipment that they needed to do so. So I suppose releasing the data in and of itself is probably necessary as part of helping everybody to understand what happened during that crisis. But it is really important that the narrative that sits around that data release isn't one of demonising either individual providers or the sector as a whole, because we know how the sector already, we know how the sector was failed by the government in multiple different ways throughout the pandemic. So I think that's my take on that. It isn't, I have to say, we haven't discussed it as an APPG, so it's not the view of the APPG, it's just a personal view.
Great, thank you, Helen. And staying with you, Helen, Gareth Bradshaw asks, throughout the white paper, there is a tendency towards creating broad enabling powers for the Secretary of State. Why would these powers be needed outside of a pandemic in the future? And will these powers affect social care?
Yeah, I would share that concern. I have to say that in a narrative around ICSs, which is about local delivery across specific geographies, that there is also then this pull back towards the centre and back towards the Secretary of State. And I mean, I hope you have the opportunity to ask the Minister about that later. She's previously said that this is just about formalising something that happened during the pandemic around direct payments and so forth, and that it isn't a kind of big deal in policy terms. But I think it has to be set against a narrative for social care, which is very, very far from the empowering narrative and set of policies that we really want to see for the sector. We want to see social care provided in choice and collaboration are so important in social care, and we want to see social care being delivered in ways which empower individuals to make choices about their own lives and empower providers to deliver the level and the quality of support that people need. And I think if the sector feels like it's being increasingly overshadowed and directly accountable to the Secretary of State, that isn't a narrative about local empowerment. It's a narrative about greater central control.
Great, thank you, Helen. The next question, I'm going to give a view myself before passing back to you, Helen, again, if that's okay. So this question is from an anonymous attendee who says, do you think that the public would ever accept funding social care in a similar manner to the NHS? It would be wonderful if social care could similarly be free at the point of use, but given that there are doubts over the sustainability of the NHS, I'm just very worried about the financing of social care, particularly for elderly people who, for whatever reason, have not been able to save much towards their retirement. So I'm just going to give a little bit of a perspective myself on this, because this has come up very, very regularly throughout my career. And I think one thing that has struck me, particularly when I used to work directly in local government social services departments, which means I was more close to the impact of voting, if you like, on the outcome of social care, was a couple of things. One was that whenever the council I was involved in made any move to increase council tax levy to pay for social care, they tended to lose a vote. The other side of that story is that when councils had made a decision, for example, to close a care home, and I'm thinking of a particular area here in North Yorkshire, the first time in history it lost from Conservative to Lib Dem because it made a decision to close a care home. So on the one hand, my experience is that people are not invested in social care. If it doesn't personally affect people, they don't know about it, whereas something like the police, the NHS, teachers, waste, whatever, affects everybody all the time. Social care is not at the forefront of people's minds until it affects them. And when it does affect them, it tends to be an elderly relative needing to go into a care home or something similar. So I think that there's something that everybody that on this call can do, and everybody involved in social care, is about being an ambassador for social care and raising awareness more widely so that people do realise that social care may affect them or their family members one day, but even when it doesn't, it affects a really wide number of people. And then if we think about things like what became the dementia tax a few years ago, that significantly affected the outcome of an election. So I think the public can be swayed to see how important social care is, but it doesn't come easily to them. But I'm interested in your view as well, Helen, if that's okay.
Thank you. Yeah, we accept with health that ill health and the need for healthcare happens to people at random, that it's an accident of the circumstances of your life that means that at different points some people will need very high levels of healthcare and support. Some people will remain comparatively healthy throughout their lives, but the risks of that should be shared across society and not fall on the individuals who happen to be unfortunate enough to fall ill or to have a serious accident at any time in their lives. And we haven't historically accepted that the same is true for social care, but I think we should. So I think it is in much the same way as your need for NHS care and treatment is an accident of the circumstances of your life, can happen to any one of us at any point in time. The need for more help and support in daily life is the same, isn't it? Any of us could have an accident or an injury that means that we need care and support as a working age adult. Any of us could develop dementia or frailty, or for any one of a number of other reasons need care and support when we're older. I can only really speak about the work that I've been involved in previously through the Housing, Communities and Local Government Select Committee, when we did a really big inquiry in the last Parliament on the funding of adult social care, and that was the first inquiry on adult social care that had used what's called a citizens jury, where we took it was a really well-funded piece of work. We took a large group of citizens, representative of the makeup of society as a whole in terms of their demographics and their political views and beliefs, and did some really intensive work. So we gave those people a lot of information about social care and how it works at the moment, and what some of the consequences are in terms of costs for people, and how social care works at the moment. And we talked to them about how they think it should be in the future. And what came out of that piece of work was a broad consensus that care should be free at the point of delivery, that those risks should be pooled across society so that nobody should have to face catastrophic costs at the point that they find themselves in need of care, but also that we as a society have to pay for that care and support as well. So I think this is a moment to, I'm not going to prescribe what the funding mechanisms should be. That's a much more complicated piece of work that the government needs to do on a cross-party basis, but there are plenty of options available. But I think this is the moment, as the post-war period was for the NHS, where we have to say no longer can we go on with a care system that delivers such widely varied outcomes for people. No longer can we go on with a care system that hits some families with catastrophic costs but not others, and we have to build the care system that any one of us, should we have the accident in our lives of finding ourselves in need of care, would like to be there for us and would want to be able to draw on. And this is about mature political debate. It's about proper engagement with citizens, with taxpayers, about what we need to deliver. It's about transparency, and it's about, you know, defining a vision that people will feel happy to buy into. And nobody's pretending this is easy, but we simply can't go on in the way that we have for far too long, in not biting the bullet on this issue anymore.
Yeah, here. Thank you, Helen. I'm going to go back to Vic for a couple of questions, if that's okay. So Vic, from an anonymous attendee, so many wise words. As a very disillusioned home care provider, what do you consider to be the best and most effective way we as providers can gain a louder voice? How can we campaign for a better care system when locally we have statutory organisations that won't listen? Unless we can be part of the solution, we really are part of the problem.
Thanks, Catherine. And I just wanted to quickly just jump in on a bit on what Helen was saying as well, and I think it's part of that answer, is that I accept Helen was saying, you know, that no longer can we go on. I think the really big problem is that actually we're 25, 30 years too late to this discussion about social care reform, and that is part of the challenge. And I think to the anonymous attendees point is that, you know, one of the really big difficulties about all of this is that it's now such a crisis and such a critical problem that any of the solutions to it are very politically unpalatable. Helen mentioned, you know, Catherine, you mentioned the sort of the dementia tax and various things that have been tried and looked at, and obviously we have the Deal Not Cap and the Care Act. You know, we have a lot of those mechanisms there, but they are very difficult to think about how they can be implemented at the scale and speed that is necessary. And I agree, we have to reframe social care in the context of something that people come, and the need for that comes along at a point that people might not necessarily be able to control. But I would also suggest that we've got masses and masses of demographic data that we've known for years that suggest there is a huge cohort of people, certainly in terms of older people's care, coming down the road who are going to need it. And I think, as Lynn has pointed out in the Q&A as well, there is also a very, very large body, millions and millions, 7, 8, 12 million people, I think, during COVID, who are unpaid carers as well, who are very familiar and connected. So I'm not sure who these people are out there who don't see the value of social care and who aren't connected to it in some way or form, in the same way that all of us are connected to the health system. So it's really, I find it really hard to answer the question in a sense, but that doesn't mean that I think social care is part of the problem. I think what it means is that we need to rethink the description of the problem. And I think whilst we're busy talking a lot about the need for the money to come into social care and the reform around the funding, we probably need to rethink some of that narrative. So we're much more focused on the opportunities that social care can create and the investment and the return from social care. So some great research done by Skills for Care and partners, including NCF, a number of years ago, about the net return of social care, for example, which is 43 billion, I think, on an annual basis. So this isn't a sector which takes money away from other local priorities and initiatives. It's a sector that contributes to the local economy. It's a sector that contributes to the ability to local people to work. It's a sector that is probably in many areas the largest employer if you aggregated all the organisations together. It's, you know, it's a sector that, when it's done really well, absolutely changes the lives of people who are receiving care and support. And I think that's the bit that social care can do. That's the bit that we can all do, is reframe some of that discussion so that it's not seen as social care coming with its begging bowl to the table, but that it's absolutely a fundamental part of all of our lives and all of our local communities and economies. And there's so much we can say together that will help get that message through. So, and I think that's why when we talk about reform, we need to be thinking about making sure we grab hold of that agenda and make it really clear that this is not just about people not being able to, not about having to sell their homes to pay for care costs. This is about having something that works for people now and works for people in the future. And we've known for a very long time what the future would look like, and we are precariously close to not being able to turn things around in a way for the workforce and for people who receive care and support unless we act quickly.
Great, thank you, Vic, and I couldn't agree more. We're out of time for questions. I was going to take one more, but I've just noticed the time, so we're out of time for questions. So if I could ask Vic and Helen, if you can see the questions in the Q&A, if there's any that you think you can add to in a written form, then you can click type answer and put your answer in. Otherwise, we will move on, and thank you very much to both of you. That was really, what an amazing question and answer session, actually. I think that's one of the best ones we've had, really, really engaging, so brilliant, thank you. Okay, so moving on now, I'm going to introduce our next speakers. The slide that's coming up now is just to remind you all to get nominating, don't forget about that. And if I can just touch on as well the question about captions. We have been trying to get captions on the screen. Unfortunately, as you can see, it's not working properly. So we will try and get that right for the next time, and we do apologise for this time. We just can't seem to get it to work properly. So I'm now going to introduce Gavin Edwards. No, I'm not, sorry. I'm going to introduce Rachel Dodgson and her expert by experience, Chelsea Lovell. So Rachel has worked in social care for over 30 years. She's a qualified social worker and has worked in a wide range of roles. This includes several years working in both support, registered manager and operations director posts in services for adults with learning disabilities. She's also worked for Birmingham People First and spent 13 years working for the Social Care Regulator on strategy, regulatory frameworks and policy as head of adult social care policy. Rachel is passionate about ensuring people have choice and control over their lives and delivering high quality support. And I'm sure Rachel will introduce Chelsea. Over to you two. Thank you.
Thank you. Good morning, everyone. It was also a slight long biography. Chelsea, do you just want to say a bit about who you are and what you do in Dimensions?
Hi, I'm Chelsea. I'm a person that they support within the organisation in Dimensions. I'm on the Dimensions Council, so which is a group that Dimensions gave us a space to speak about, and I'm also employed by Dimensions to be a quality consultant, so I get to interview all high-end staff and stuff.
Thank you, Chelsea, that's great. And we were just going to start off, weren't we, this morning by talking a little bit about the support you receive. Tell us a bit about the support you receive.
So the support that I receive, I'm just checking. I live in my own flat, and I live in my own flat. Before I was in a supported living, and I get about 10 hours support a week, around about that much. So they come to I now have them come into my place, but when I was in supported living, they were like on my doorstep. Now they're not.
Yeah, and I saw yesterday you've got a great timetable that organises all your support workers in terms of what you need. Could you tell us a little bit about what's important to you about your support?
As we talked about yesterday,
yeah,
I like the friendships that I have with support workers, and I love having a bit of banter with them. It's great fun. I like how encouraging they can be, and that's quite a good thing to have, is the encouragement. Sometimes they suggest things like, you know, out of 3 things they might suggest something, and then sometimes I'm like, oh yeah, let's go and do that, and that's fun. It says it's important I think it's very important that I have a good relationship with support workers, because you don't want to have one that you're miserable with or something. And I think it's very important to have long-term relationships, because you can always go back to them and talk to them in that sort of way, so they know all about you.
Yeah, that's great.
Like what happened.
And then the last thing we're just going to talk about in this bit, wasn't it? But were you going to say a little bit about what's great about your life now and what could be better?
I've had a great in the time of COVID, I've had a great time. I've joined the Dimensions Council. Well, just before the pandemic started, I joined the Dimensions Council. I only managed 2 meetings in person. I've moved into a more independent living setting during the 2nd lockdown, because you could move. I have a new job. I did have a job with Dimensions. I spent all the time cleaning the stairs. Great fun. And this one, I've managed to join Tracy's equality consultant team, so that was great. I've done loads. I've done online courses. I've flourished. I do stories, and I want to go out a bit more. You know,
you want COVID to go away, don't you, and get out a bit more. Thank you, Chelsea. That's great. Can we move on to not the next slide, probably the one after that? Can you move to the next slide, please? Yeah, so I won't repeat this. It's interesting that several people have already raised this morning, and I think if we think about what Chelsea's just set out for us in terms of her life and what matters, that really lives up to what's saying on the screen. In this session, we haven't got a lot of time, but we want to talk a little bit about why we think co-production is important. We want to talk about an example that we've got from Dimensions in how we've done some co-production with primary care, and also what we think the government and the systems need to do to make co-production a reality for the white paper. If we can move to the next slide, please. So Chelsea, can you remind me, we talked about this yesterday, why is co-production important?
It says it there.
What's your view? It says it there. What do you think? Why is it important for you?
I was talking, as I said, I was done a lot of courses, and I was and I realised that people that are supported are stakeholders in the organisation, and we need to have our say. And you know, we're quite big. It's all about the person. So we should definitely have a say in it.
That's right. And as well as being a stakeholder in the organisation that you are at Dimensions, people are also a stakeholder in the system, aren't they? So we talked about the system and the importance of that. So I guess from our perspective, we put some of the things there about why we think co-production matters, but it does lead to better outcomes because services really respond to what people want and need. We make better decisions if we involve people and we co-produce things with people. And our experience, it can make a real difference. And as we'll talk about the primary care experience, we've got some real tangible evidence there. And I think the other thing that's really important about co-production is genuine co-production is involving people at the beginning. So not putting out a white paper that people haven't been involved in co-producing the thinking behind. So that engagement early on is really, really critical. And I think the white paper is strong on person-centeredness, but it's less strong on co-production. And both of those things are important, but really the white paper is more focused on being person-centered. Could you move to the next slide, please? Just want to talk a little bit about joined up systems working together. So this is a really good example of how we can make systems work together, and system work that we have done with primary care. So people will know that people with learning disabilities die more than 20 years earlier than the rest of the population, and generally from things that could have been avoided, so avoidable deaths. So we did some research and we spoke to over 250 GPs and over 600 people with learning disabilities or autism. And the results of that were that 98% of GPs said they'd benefit from training led by someone with lived experience, and 74% said they needed training on reasonable adjustments, and only 22% of people with learning disabilities or autism said they felt independent in their primary care setting. So Chelsea, can you just tell us a bit about your experience when you go to the GP? What's that like?
Well, I haven't been to my current GPs, but I can tell you about the last GPs.
Yeah, that's great.
Because I have more experience. I found it all right. I know that's vague. Of course, people get annual health checks, and I had I think the same nurse for 2 years in a row, and I knew what to expect because I went, oh yeah, you did me like that, and so that was quite good. So you had that regular conversation, and of course I felt she was engaging. Like when I like it when they're engaging and they talk to you. That's important.
That's great. So you had a really positive experience with your nurse and your GP, which is really positive. I mean, what we did in Dimensions on the back of the feedback and the things that we heard is develop free training with people with learning disabilities and those that support them to make GP services more accessible. And we've had some really great feedback on that from GPs. So the training was driven by GPs. It was co-produced with primary care by Dimensions and a lot of the people that we support, and we've been rolling that training out. And there's a web address there. It's free. We're trying to get as many people to use it as possible, but we've had really good feedback on that. And just, I suppose, a really great example that I heard about primary care the other day was that somebody we support with autism was really struggling to have the vaccine, was really reluctant. We had a GP that came out and spent 40 minutes with that person talking to them about the vaccine and why it was a good thing to do. They then came back the following week to finish the conversation because they could tell the person couldn't do it, couldn't manage the rest of the conversation then, and the person's had the vaccine. So for me, some really great examples of actually how we can make the systems work together. Can we move to the next slide, please? Next slide, please. Thank you. So has the white paper itself been co-produced? Well, if any of you have done a word search on the white paper, you'll have spotted potentially that the word co-production is mentioned once in the white paper. So I think it doesn't set out the vision. We think it doesn't set out the vision for co-production. It doesn't appear to have been co-produced. The next slide, please. Chelsea, we talked a bit yesterday about the white paper and how you might engage with the white paper. What do you think about it?
Well, we were talking about it yesterday, and you told me a bit about it, and I think we should have a simplified version, you know, not all the jargons. I won't be interested in all the jargons and what this thing and the little words and stuff. I think a simplified video is would be great, so I can watch it and then I can have someone explain it to me. Animations are fun. Why can't we have an animation? That should be on it.
Thank you, Chelsea. That's great. So that's the problem, isn't it? It's very technical. And how can we actually do genuine co-production if we're not giving people the materials and documents that support that engagement and help people understand? So there's got to be not too technical. Yeah, there's got to be more done to remedy that, to make the reforms real to people, as Chelsea's just set out to us there. Can we move to the next slide, please? And so the policy itself, does that actually insist on co-produced approaches? Could we move to the next slide again, please? I think we've heard this from some of the other speakers this morning. It's not clear what the role of citizens or people with lived experience will have in those ICS structures. It's not clear how their voices can be heard or how they'll hold those structures to account. We think there should be an expectation within those ICSs to employ experts by experience, particularly to inform certain aspects of work in the same way that we do at Dimensions or NHS England does. Chelsea, do you want to say a little bit more about your role at Dimensions? Some of the things that you do?
Oh yeah, I can do that. My role in Dimensions is I'm one of the council members. So there's a whole group, a bunch of us, and I propose ideas and opinions. I'm called the ideas lady by my boss. I advocate for people's rights and talk about you know, learning disability and autism, and I really do think of it as disability politics. We need to start using that, disability politics, when doing it. And the council influence Dimensions because there's a space for us to speak, and that is so important that I have a place to say to Dimensions, let's do this.
And you, so I know the representative of the Dimensions Council comes to the executive team meeting every month and tell us about the big things that are on their mind, and we try and do things about that. And equally, they go to the board meeting. The council meets the board meeting once a year. Can you tell us, Chelsea, what difference you think the council makes Dimensions?
I think the organisation does listen to what we have to say. You know, we want this, we think that. And during last year, this year sort of time, we talked a lot about the access of technology. Not everyone can use it in the pandemic. Sometimes the support workers aren't good at it. Sorry. So yeah, the pandemic that led a project to help people get online and stay connected. So we had some groups for that. And then of course we do speak to the board every year. So I think that's quite powerful. So we do have that space, as I said before.
We try to make sure that your voices get heard at the top of the table and the top of the organisation, that we do something about that. So I guess from our perspective, that's what's missing in the white paper. It's not clear how that voice is going to be heard at the top of the table and really involved. And again, as Vic commented, co-production is not only about how we involve experts by experience, that's really important, but it's also about how we involve providers, the voluntary and community sector. And it does seem that local government is the main voice of social care within those partnerships, and it's got to be that we've got to have other people having a seat at that table. So if you can move to the next slide, please. So we've got a bit of a bridge here with a gap in the middle of it, and so how can we in social care help to bridge the gap? If we can move on, please, to the next slide. So I think really there's a lot that can be learned from social care. So we already practice co-production in social care. We know that a lot of local authorities do that really well. It's a starting principle for many providers, not just in Dimensions. So it's how the ICSs can learn from that and really take that on board and embed it across health and care. And we also know there's a lot that social care can do. People have mentioned this already in terms of prevention and making sure that actually people don't end up needing to use health services. So we've got nutrition volunteers in Dimensions that have helped people get healthy, lose weight, that's stopping people then accessing healthcare services. There's got to be the focus on collaboration and accountability about how systems work together to help overcome some of those real inequalities that are impacting people with learning disability or autism. For example, the work on health action plans, Chelsea talked about that, that's really critical to maintain health and well-being. And some of those issues could be better tackled by proper integration, and they'll be most effectively solved if people who use services have a role in driving decision-making, both at an individual level and within the structures. One of the specific things in the white paper is an assurance framework to give greater oversight of commissioning and provision. And that's exactly the sort of thing we think needs to be co-produced. People need to have confidence in the way the systems are operating and be able to hold them to account. And the white paper talks quite a lot about working with partners across the system, but there needs to be a firm commitment to co-production. So the white paper guidance needs to really underline the role of involving providers and community organisation as well as individuals. And that guidance needs to be co-produced as well as the expectations about co-production at a local level. And we're going to move to the last slide, and I'm going to leave the last word on this to Chelsea, and then we're done.
Nothing about me without me. Oh, what was I meant to say?
You were going to say nothing about without, but you said it perfectly. Thank you.
Yeah.
Thank you so much, Rachel and Chelsea. That was really great. If anybody's got any questions for Rachel and Chelsea, we'll try to come to them at the end. If you put them in the Q&A box as before, that would be great. I'm now going to introduce Gavin Edwards. Gavin Edwards has been with Unison since 2007 and is now Senior National Officer for Social Care. He has previously worked as a parliamentary researcher and in local government. Over the period of the pandemic, he's led Unison's campaign for adequate PPE provision, better wages, proper sick pay and other improvements in the social care sector. Gavin is lead negotiator with national care providers for his union. Unison regularly represents care members in meetings, officials and ministers at the Department of Health and Social Care, and is the largest trade union for social care workers across the UK. Over to you, Gavin. Thank you.
Thanks very much. It's great to be here today. So I've been asked to speak about making social care a career of choice and raising the profile of social care as a profession. The obvious implication is that there's a problem with the profile of the social care workforce and that it isn't currently a career of choice, which is something that's been touched on by a number of other speakers already today. So I start from the assumption that people working in the care sector and people who might potentially work in the sector are smart and have a pretty accurate impression of what working in social care is like. And this is what I think people know instinctively or by looking into the detail themselves about the sector. First of all, they won't be well paid for the job that they do, given the skills and hard work that they need. In fact, they'll almost certainly be paid very poorly for the job that they do. They probably won't be listened to. Most social care workers, for example, don't recognise trade unions. I've never been backwards at coming forwards when it comes to criticising when it's necessary. But, you know, I would just mention that as we've got speakers from Dimensions here today, they are an organisation that recognises Unison. And though we might not always agree, they are an organisation that's always taken a very grown-up approach to engaging with trade unions. But sadly, that's not always the case. People are often overworked in the care sector, particularly because of the high vacancy rates. They won't have a career structure or adequate training. People know that if things go wrong, there's a high chance that they will be blamed rather than supported. And they often don't get the respect they deserve and probably don't have job security. Now, not all of these things are true for all care workers, of course they're not, but they are generally true for the majority. 3/4 of care workers are paid less than the real living wage. Only 45% of care workers have a level 2 qualification, which is the recommended minimum for care and support workers. And 25% of all care workers are on 0 hours contracts, and that rises to 50% when we're talking about domiciliary care. So there isn't a smooth, emotive government advertising campaign which will overcome these facts in the long term. Unless they are addressed, we will continue to see skilled care workers leaving the sector and employers having to deal with unmanageable vacancy rates. And most importantly of all, this damages the quality of care for everyone who calls upon the care sector to help them to live their lives. All of us need to understand why this is happening and then address the substantive issues instead of continuously trying to sweep them under the carpet. The causes are complex, but I think they come down to some basic reasons. First of all, acute underfunding. Several of the speakers have already mentioned that today. It seems so obvious and widely accepted that I hardly need to dwell on that point. There's also been a historic failure at the Department of Health and Social Care to take responsibility for a sector which is in its very name. Ministers and officials often seeing the sector as a distraction or an inconvenience instead of what it is, a vital public service. Nationally, there has been virtually no structure for dealing with workforce issues, a completely misplaced faith, in my opinion, in the ability of the market to deliver. There's also been a general failure to appreciate the damage that can be caused by a race to the bottom on terms and conditions, which is what we have seen in many parts of the country. And finally, there's been a failure of stakeholder engagement and partnership working, although, as I'll mention in a moment, I think that is changing. None of these things are true in the NHS. There's no equivalent is true for any other functioning public services, but they are all true for the social care system in England. So that's perhaps enough of me being negative and generally getting these frustrations off my chest. We need to ask, how do we fix this? The first thing is to say we need a durable, long-term solution, not sticking plasters. The time for half measures has long passed, and the government's promise to come forward with social care reform proposals must be used as an opportunity to address these issues of workforce problems for the longer term. What care workers and care employers need in social care is a framework, a plan, the knowledge that government will coordinate change and move the system from dysfunctionality and incoherence to a new set of agreed rules that everybody can play by. The way to do this is for government to put together a wide-ranging people plan for social care, a strategy that addresses career structure, qualifications, training, pay, stakeholder engagement, and partnership working. There should be funding for and a guarantee of all care workers in the UK being paid, at the very least, the real living wage as calculated by the Living Wage Foundation. I have to say that one positive that's come out of events over the last year is that the Department of Health and Social Care has finally started to reach out to trade unions, employers and other sector stakeholders and bring them together to engage with the sector. The Social Care Task Force being one example of this. It hasn't been perfect, but it's been better than what came before. Government should build on this and create a national social care partnership forum between national government and local government, employers, representatives who those who draw on social care and trade unions. As part of this, there should be a mechanism to negotiate terms and conditions for the social care workforce, including annual reviews of pay, similar to arrangements that are in place in the NHS and local government. Precisely these arrangements are being progressed in Scotland, Wales and Northern Ireland. And there's absolutely no reason why the same shouldn't happen in England. I also think that the government should consult on a national compulsory register for social care and support workers. This would help to raise the status of the profession and increase the recognition that social care workers receive. These structures would provide a mechanism to put in place nationally mandated training standards, providing clarity on the required skills and competency frameworks, and set out the obligations on employers and employees regarding the availability and take-up of continuous professional development for care and support workers. And that includes personal assistance as well, similar to the model that's taken up by social workers. To achieve all of these workforce-focused measures that I've set out here, you don't have to believe in a particular model for social care delivery. At Unison, we believe there should be a national care service, publicly controlled and delivered, a system that takes the profit making out of social care. But there are alternative models, some we like much more than others, but workforce measures like partnership working, making sure people get sick pay, professional development, do not presuppose any particular model. The government is free to implement these measures. It simply needs to have the political bravery to move forward and implement them. On Thursday, the Future Social Care Coalition, which Unison is a member of, will be publishing a framework document for a people plan for social care. This is a comprehensive document widely consulted on with a broad range of employers, politicians, charities and others who want to see a world-class social care system in this country. We will be urging government to take up these proposals and incorporate them into its programme. Over the last year, we've seen far too much of people saying nice things about care workers and clapping them, and that's been good. It's not an either or, but we have to move from these gestures of support to real support for the care workforce once and for all. So I hope that's been a fair stab at addressing the issues we're faced with. Thank you for listening, and obviously happy to answer any questions.
Thank you so much, Gavin, and we have got a couple of questions for you in the Q&A box, which I will come to at the end. So I'm now going to introduce Laura. Again, if you've any questions for Laura, put them in the Q&A and hopefully I will get to them at the end. So Laura leads the healthcare team in advising providers of adult care homes, nursing homes, supported living facilities, independent hospitals, children's homes and schools throughout England and Wales on a range of issues. Laura regularly represents clients in challenging inspection reports and defending enforcement action by regulators such as CQC, CIW or Ofsted. This includes action by the regulator to refuse or vary registration, impose conditions of registration or cancel registration, including appeals to the Care Standards Tribunal and urgent actions before a magistrate. So over to you, Laura. Thank you.
Thank you. And thank you very much for that kind introduction. I suppose, as you've touched on there, my title, abbreviated version, is Head of Healthcare. I'm actually the Head of Healthcare, Social Care and Community Care. And the reason I say that is because I've been asked to talk today about why it's important that local authorities fulfil their obligations and their duties, in particular under the Care Act. And we spend quite a lot of time assisting both care providers and individuals in relation to cases where, very sadly, local authorities haven't done that. Suffice to say, it's frustrating and more, but we see it from various sides, and so it gives quite an interesting perspective. On one hand, we're often acting for individuals under our community care subdivision, where we are challenging failures to provide care, which the local authority has a duty to provide due to the person's assessed needs. Also in relation to SEND provision, we have a lot of challenges there. And on the provider side, we're regularly challenging local authorities who aren't paying a fair cost of care, aren't fulfilling their market shaping obligations under Section 5 of the Care Act, or in relation to things like ordinary residence disputes. And one thing that we are seeing increasingly is that a lot of this is being driven by money. Local authorities seem to make decisions based on, regrettably, financial considerations, and it isn't always the person-centred decisions that's in the best interest of the individual, and they're not always getting what they're entitled to. And I would echo what one of the other panelists said earlier, that the individuals need to be at the centre of this, and it makes such a difference to someone's life to receive, and I can see Chelsea nodding there, to receive the care and support that they need. And sadly, far too often, we find that's not the case, and it does make a significant difference to people's lives when we win those sorts of challenges and people do start to get the packages of care that they are entitled to. I think it's very frustrating, very sad that actually we should have to go through that process, and people should have to instruct people like us in order to get those packages of care and support that people are entitled to. Looking at it from a provider perspective, we saw a lot of problems last year during the pandemic, in particular around last April, where we had obviously inflationary increases and national minimum wage, increased additional costs due to the pandemic, and yet an awful lot of local authorities giving no annual fee increase whatsoever, or refusing to engage and say what they were doing, which created a lot of problems for care providers at a time of immense stress and instability. So it's absolutely crucial for a whole range of reasons that local authorities do what they're supposed to do and fulfil their duties under the Care Act and indeed other legislation, both because of the impact on the individual, but also in terms of the funding of the sector. A lot of residential services, as well as supported living services and domiciliary care, are dependent on that funding stream. And clearly, if we're going to be in a situation where the costs that are being paid by local authorities aren't sufficient to meet the costs of care, then that places a risk to providers within the sector, and that is something that many clients have expressed concerns to us about, particularly over the last year, with increasing costs of agency staff, etc., to backfill staff absence during the pandemic. It has been particularly problematic. So one thing I was really pleased to see actually in the white paper is that the white paper does appear to recognise that it's absolutely crucial that local authorities are doing what they need to do. More and more people are having to resort to the support of local authorities and the social care system, and that is going to continue in years to come. That is not going to decrease. And the local authorities are very much at the forefront of dealing with that challenge and making sure that system works effectively. And the white paper really seeks to highlight the need and the crucial importance for the delivery of a high quality service and high quality outcomes as part of that system by local authorities. And there's a real emphasis on the need for personalisation and choice and early intervention. And this is why it's so important that co-production, I think, absolutely is crucial in understanding that. And what the white paper seeks to do actually is increase accountability of local authorities, which is pleasing for me to hear, because it is always frustrating when we have to go off and complain to the Department of Health or ask for the Secretary of State to intervene on things like ordinary residence disputes, or where we have to ask the courts to intervene, because frankly we shouldn't have to. And what the white paper proposes is actually introducing a new additional duty for the Care Quality Commission to have an additional role in assessing how local authorities are delivering and complying with their Care Act duties. That's something that is going to be quite a change. Local authorities haven't fallen within the jurisdiction of CQC or its predecessors in any way for some significant time now. So this will be a completely new system. At the moment, we don't quite know how that's going to work. The intention is that it will be, the duty or the power will be secured in primary legislation as soon as possible, with the detail to be worked out thereafter to develop a scheme which is intended and hoped to be sustainable long term in and effective in providing and ensuring consistency in local authority compliance in the future. And it's particularly interesting to see that actually there's proposals to, on top of that duty for CQC to assess, there are proposals for an additional power for the Secretary of State to intervene where CQC has assessed that local authorities are failing to meet their obligations under the Care Act. So I think that this is really important. This is going to be an increased level of scrutiny on local authorities and actually make them more accountable for the decisions they're making, the things that are happening. And I think that's needed. That is absolutely needed in order to make sure that things are being delivered as they should be, making sure that people are receiving the services they should be, and making sure that local authorities are complying with their statutory obligations under the Care Act. We don't know at the moment the details of that. I personally will be very interested to see what the detail looks like, robust in their assessment of local authorities as they are with care providers. And I guess I await with interest seeing more details of that process and how that's going to work and the criteria for the Secretary of State intervening if they need to. But I would hope that it will pull local authorities a bit more in line and make sure and act as an extra incentive to them to make sure they are complying with their care obligations.
Thank you so much, Laura. That was really great. Thank you. If anybody's got any questions for Laura, put them in the chat and I'll come back to them afterwards. So I'm going to come to the questions and answers now. Before I do, as we've been talking about co-production, I just want to highlight that it is co-production week on the 5th of July. I've just put a link in the chat if anybody wants to find any of the resources that SCIE, Social Care Institute for Excellence, have produced to support co-production week. We've got a lot going on and it would be really great if people engaged with that and learnt more and more about how we can all get involved with co-production. As Chelsea very rightly said, we should all be thinking nothing about us without us when we think about people that are drawing on care and support. So I'm going to move to the questions and answers, and the first questions are for Chelsea. So the first question, Chelsea, your work is admirable. How do you make sure you provide a voice for those with more significant difficulties who may not be able to have as much of an active voice as you do? That's a hard one, isn't it?
Yeah. Well, the thing is with my team on the council and in the quality consultant is there are quite a variety of us, so we all have different needs and we all have different needs and different communications, and some of them have been on there for years, so that they give us a little bit of insight. There's one guy, and you know, he can be really insightful in that sort of sense, so you sort of have to pick up from the others, because I only was in the council for a year and less than that, so it's still sort of new in some ways to me still. But you know, I've done it for years, that I have sort of spoken up for people with who find it difficult for years before I realized what I was doing when I was a teenager. You know, they can't walk, you know, like that, so that sort of thing. So yeah.
Great, thank you, Chelsea, that's great. Okay, the next question is for Gavin. In fact, the next 3 questions are for Gavin. So Gavin, the first one, you've talked a lot about staffing, and it has previously talked about difficulties in recruitment. How do you feel that the proposed mandatory vaccines for care staff will impact on this already difficult area?
Yeah, I think this is a real worry. People probably have seen a lot of the media coverage that's happened over the last week or so, with the government deciding to move ahead with this. We think this is the wrong move, and there is a risk of creating even greater problems with short staffing in the social care sector as a result. We think, we strongly support the vaccination programme as the way of making social care workplaces safer places, and we've been encouraging our members to take it up. But the key is persuasion, not coercion. There's a whole raft of academic and other evidence which shows that that's the best way to go. In Scotland and in Wales in particular, there's been no mandatory vaccination, and they have much higher vaccination rates than in England. I think the reasons for that are many and varied, but what we would urge the government to do, instead of going for mandatory vaccination, is to put all of the resources that they will waste on that and make sure they focus it on the areas and the care homes where there's low uptake. Make sure they do what works, like peer-to-peer reassurance with care workers, and go for persuasion, not coercion.
Thanks, Gavin. And the next question, do you feel that a social care union would gain more recognition and respect with a national care service? Nurses, doctors, teachers, the police, etc. all have unions as state professions which seem to have the government's ear.
So I think I'd push back on the basic premise of the question, which is that there isn't already a social care trade union. There is, and it's called Unison. And there are other unions who organise in the social care sector, notably GMB and RCN as well. But Unison's the largest union in the sector. We've got 185,000 members, and that's growing very rapidly. We're putting more and more of our resources as a union into making sure that we organise properly in the social care sector and represent people. The fact that we're in such a strong position already, even in a sector where there are large numbers of employers that refuse to recognise trade unions and don't even give us access to workplaces, obviously outside of pandemic period, it shows that there is a strong voice for social care through the trade union movement. And as for having the ear of government, probably I was in 3 or 4 meetings last week with the Department of Health and Social Care and many of my colleagues at Unison as well. So we feel that we've become a strong voice both to government and in the public debate around social care, and long may that continue.
Great, thank you. And the next question for you. Everything you said is extremely welcome to us all in the sector and would go a long way to help raise the profile, but this has been a problem and talked about for generations, and we're so used to the limelight being focused elsewhere in the end. How can we be sure that these changes will happen this time?
Yeah, I thought both Vic Rayner and Helen Hayes dealt with this issue very well in their speeches. It's time this happens now. Everybody has had enough of promises made and promises broken on social care. We need the funding, we need the reform, and that needs to be done in the right way. I personally, I'm a natural optimist, and I think that it's going to happen now. I think the level of political pressure and momentum that is behind this now, particularly now that so many more people are aware of the importance of social care, given everything that has happened during the pandemic. I think it would be completely unsustainable for the government not to actually move ahead with this now. Obviously, it remains to be seen if they'll do some of the things that I've been suggesting and that others have been suggesting today. But I think there will be a significant move to reform. We just need to make sure it's done in the right way.
Great, thank you. I may come back to you with some questions if we've got time. In the meantime, I'm going to move to Laura for the next question. So Gareth says, I find the discharge to assess model concerning. They want to introduce assessments after an individual has been charged from acute care. This is just another example of services not wanting to deal with the issues of the individuals in the care sector and wanting to send them to the provider as soon as possible. If this model is allowed, providers won't be able to create support plans and give person-centred and an acceptable level of care that are created by the assessment. Do you agree?
That's an interesting question, actually. I mean, discharge to assess, you know, it already exists. It has been happening for a little while in certain places. I think people seem to have mixed views on it. Clearly, it's beneficial for getting people out of acute hospital settings, and particularly that's been a real motivating factor during the pandemic to free up hospital beds. Some people really don't like the process at all. I've got clients that are doing that sort of thing at the moment, and actually say, look, you know, apart from the fact that there's not always a clear clarity around exactly what the expectations are, and the goalposts move a little bit from time to time, that on the whole, it seems to be working fairly well, and they're quite happy and looking to continue to do that longer term. So it is around actually having clarity on exactly what the expectations are for providers, how things are going to work in practice, and actually.
Thank you. I think we just lost you at the very end of your sentence there, but I think we got what you were saying there. The next question is for you also, from Kevin. How will these increased powers of the CQC over local authorities transfer and integrate with the integrated care systems and healthcare?
Yeah, and again, I think that's a really, really good question. Unfortunately, I don't know the answer. We don't know how that's going to work yet. All we know is that a duty is being introduced for CQC to undertake these assessments. CQC won't be regulating local authorities in the same way it does with adult social care services, so there won't be an obligation to register and be regulated and rated in quite that way. It will be some form of assessment process, but we really don't know quite how that's going to work. There are discussions. I think the white paper says that once it's been introduced as a duty into primary legislation, then there will be co-production of some description with local authorities or CQC, I'm assuming. Whether they'll involve anyone else in that, I don't know, probably not. But there will then be work to design a system and how it's all going to work together. But I'm afraid I don't know the detail of that at the moment, but I'm very interested to know the answer to that myself.
That's great, thank you. And I can actually give a little bit of information to that one myself, which is that I'm very well aware that CQC are working with the Local Government Association and ADAS to make sure that they get these things right and agreed before they're rolled out. So it is being, can't tell you the answer, but I can tell you it's being talked about. The next question, Laura, again for you. Is there much opportunity for local authorities to collaborate and learn from best practice, or potentially pool resources if they feel they could deliver a particular service more effectively at a higher level, often something that perhaps couldn't be supported financially at a more local level?
Yeah, I think absolutely there is the opportunity. I think the bureaucracy and the difficulty is getting local authorities to play nicely with each other. There will historically we see sort of different, slightly different agendas within different local authorities. I mean, certainly when it comes to things like ordinary residents, it feels very much as if they're in competition and they don't want to play nicely. I think there are opportunities. I directed. Cynically, perhaps that's one of the reasons they like supported living as well, because actually some of the funds come from a different pot in relation to the housing benefit. I don't think we're there in terms of the mindset of local authorities wanting to do that. I hope in the future we might, but I think we just have to see how that works. But I think there are opportunities, certainly.
Great, thank you. Thanks very much, Laura. I'm going to move to Rachel for the next question. Rachel, see what your view is on this one. So the question asks, what do we think can be done to encourage the public to view social care as a social good which deserves funding on its own merit And this was reflecting back to the comments that I'd made previously about local government. And she says that, he or she says that whilst it remains a case, it seems we'll struggle to afford to give social care the funding it so urgently needs. Any government that seeks to increase taxes will inevitably be lambasted in the media and voted out at the next election. What do you think about that, Rachel? What do you think we could do differently?
Well, I guess for those that's worked in the sector for a long time, as several people have said, it's frustrating that we hear from the same conversations. But I genuinely think that the pandemic, one of the good things about the pandemic is it's really put social care at the forefront in terms of the public and people's perception. I think people actually do understand what social care does. I think people understand the difference and the impact it can make, and you know that I think we're kind of almost in a unique springboard position to be able to take advantage of that. And I think the government needs to grasp that too and be thinking about how they campaign and how they raise the profile of social care, because I do think there's not been a lot that's been good about the pandemic, but I do think it's really helped people see what social care, what the value social care brings, and it's just how we lobby and how we really raise the profile and build on that, in my view.
I agree. I've personally never seen social care on the news quite so much as it has in the last year, but it's been focused a lot on residential care homes, and as
Absolutely.
important as they are, that's not social care, well, not social care in its entirety. Chelsea was nodding along vigorously to you there. What do you think, Chelsea? What do you think we could do more to help people understand what social care is and why they should support it?
Put us on the news.
Yeah, we need to get on the news, yeah.
You are right. It's had that thing, hasn't it, where for a few years it was all about Brexit, and now it's all about COVID-19 and social care and how we do it. So I do think, you know, we do have to talk about it a little bit more. And I went to a conference earlier on, the Learning Disability England one or something, and they feel like we should be asked what it is, and you know, people that are receiving the support, social care, to go on it, and that's what we should do, have that sort of thing. Does that make sense?
Yeah, absolutely. We all need to be talking about it more, get some stories on the news and telling people what's interesting, how they can support.
Get a group of us that have learning difficulties or whatever, and just put us more out there. That's what we need to do.
Yeah, and if we think about the things that make interesting news, it's about when things are going wrong and having a bad impact on people, or sometimes very good news stories. So we can think about how we could get some of that into the press. Thank you, Chelsea. Gavin, I'm going to come back to you now, and I'm going to combine a couple of questions because there's a similar feel to them. What does Gavin feel about the complexities of the marketplace with local authorities, self-funded, continuing healthcare, personal assistance, integrated personal budgets, and both paid and informal family carers? And I'm combining that with a question we've had about, do we recognise informal and family carers, unpaid carers? So
look, I think it goes without saying, you touched on it just there, Catherine, that you know how complex the social care system is, and it's not just care homes. There's a whole wide variety of different types of care that is provided through the system. I think the thing I was trying to concentrate on in my comments earlier was that just because we have a complex system, in a way, that there are lots of good things that come from that complexity, not least the fact that people can get tailored care that is particular to their needs. You know, that's a social care system should be able to deliver that. But that doesn't mean that we should have completely unregulated kind of Wild West approach to the way people are paid, rewarded, and respected for doing those roles and providing that social care. And I don't think there's any reason why we can't both have a necessarily and welcome complexity of the social care system, and a system whereby nationally we can come together and agree some standards and some terms and conditions for people who are providing that care. I think that's really important. You can do both. And I disagree when people kind of present it as either or, not that the questioner is trying to do that. And the second question, Catherine, you kind of mentioned another element to it.
Yeah, it was about, do we recognise the value of unpaid carers, and what's the representation for these carers?
So now that's a really interesting area. So Unison in our membership, we have people who are paid in paid employment. That's part of our kind of rules of membership. So we don't have members, people who are unpaid carers. And I know there's lots of brilliant organisations who represent those people who are unpaid carers. I think it goes without saying, you know, unpaid carers, we know, make a massive contribution to the care sector. And I think, you know, a lot of the things that I've concentrated on today, obviously because of the kind of organisation I'm speaking on behalf of, have concentrated on people who are paid. But the government does also need to come forward with proposals to make sure that people who are currently unpaid carers get the recognition and respect that they deserve, and that the reform proposals don't ignore their really important role in the care sector.
Great, thank you, Gavin. I'm going to come back to you again in a second, but first of all, the person that just asked the last question also observed that we have a very white panel today, and I don't want to leave that comment unrecognised. It is a fair reflection of the panel today. I have to say I've chaired all of these, and this is the first time it has been a white panel, but nevertheless, it's a very good point, and we'll make sure that we address that in the future. So thank you for that. Gavin, the next question for you again. You've got lots of questions here. Now, this is from Lucy Humphrey, and I have to say that I personally am not aware of the model she's referring to, so you might not be, but we'll give it a go. She says, are the Dutch Buurtzorg models and social care cooperatives a model that needs to be considered to create more ownership and better terms and conditions for workers? They would make sure teams are not overworked, underpaid, and no blame culture. Have you heard of those models?
No, not specifically those, I have to admit, but I you know, there's a kind of given a little bit of a context to it when they've made reference to cooperatives. So I'm assuming that they're talking in part about organisations who are providing care where the people who work for that organisation are joint and part owners of that organisation. So I'm aware that there are organisations like that. Look, I think it goes a little bit back to the previous question in terms of the complexity of organisations. You know, we at Unison are very much in favour of having a national care service which is publicly delivered and publicly funded. But again, that doesn't need to be a kind of single model. I think that, you know, there's a really important role in local authorities for commissioning social care at the moment. That might change, it might not. But if it continues, then I think that the knowledge that local authorities have in commissioning care, making sure that it's done by organisations that really understand the needs of people who are receiving care is important. And that can take a whole range of different organisations. And obviously cooperatives kind of find some favour with us because they're not organisations that are seeking to make a profit out of providing care. So it goes back to that complexity point. I think we can still have complexity and yet have an agreed set of standards about how people are rewarded when they provide social care.
Great, thank you, Gavin. I'll let you off the hook now. The next question I'm going to take is one that is asking, possibly linked to my last comment. Does the panel feel that including more visual diversity on platforms like today's might create more confidence in the health and social care system? My personal perspective on this is absolutely. We've run diversity conferences within this set of conferences already, and I personally believe that the more diverse representation we see in social care, health and social care, really helps to get all of the different perspectives out there and gives people more confidence that they themselves are represented at the leadership level or at the level that's having an influence or having a say. So my personal view is yes, I think that's a really valid view. Rachel, I'm interested in your view on this one.
Thank you. No, I do think it's really important. Obviously, it's been great to have Chelsea here with us today, who obviously brings some diversity to the panel in a different way, I'd suggest. And I'm sure that we all do some really great things in our organisations around diversity. It's how we can replicate that at these sorts of events. So we do reverse mentoring, where we're mentored by somebody from a different ethnic community in the organisation. And we've also done things like a critical friend, so we're involving people and sitting on panels for board members to make sure that we're not introducing unconscious bias into our decision making. So I think there's something about looking at what we all do in our organisations that's best practice and how we then replicate some of that in conferences. But I agree, it's really important.
I agree, thank you. I'm going to give the last word to Chelsea. What do you think on this, Chelsea?
Yeah, I think diversity is important at these events, and I think thank you for Rachel for saying that. I'm a person, but yeah, I think we should have you know, people from different, if we're talking about social care as general, we should have people from different ethnicities as well. And someone did say about it being a white panel, but you know, if we had people from different ethnics having different disability, then that would show different stuff, and it's all like that.
Great.
I'm nervous.
Absolutely. Thank you so much, Chelsea. Really helpful. Thank you to all of our panelists. Thank you to everybody for some really great questions. I'm really sorry if I didn't get to your questions. We had so many good questions there. If any of the panelists want to type any answers to them in the couple of minutes that we've got before we close, then please do so. Otherwise, I want to just let you know about our Care Talk podcast series. You can find that on the YouTube channel, Care Talk Mag. And I also want to remind you of your last chance to vote for the Care Awards, Social Care Leadership Awards, National Learning Disabilities and Autism Awards. Get your nominations in there. Thank you, everybody. It's been a really great conference. Somebody's just said that. Really brilliant conference, very informative and really great speakers. So thank you all and enjoy the rest of your day. Thank you. Bye-bye.